by introducing the first speaker, Dr. Kurt Zaenker. He's going to talk about Momordica charantia for type 2 diabetes, a randomized, placebo-controlled, double-blinded, and prospective clinical study as AI combination to ongoing oral anti-diabetes therapies. Let's welcome Dr. Zaenker.
Good morning, ladies and gentlemen. At first, I'd like to thank the organizing committee that I got the opportunity to talk for this in front of this esteemed auditorium. Yesterday, the session in the afternoon was so excellent, and it took a lot away from that what I wanted to tell you, take all the points. So I was really depressed because everything was said, but not by me. So I thought I will change totally the gears and come to oncology. I will explain you something why I want to do this, what I show you later, and maybe that I can spare a little bit of time. Then I can show you slowly 2 slides that we have been involved in the financial crisis in 2008 and 2009 when the banks are going bankrupt, for example, Lehman Brothers, due to the research we did. At first, we are what we are eating, and our medication is our diet, and our diet is our medication, 2,000 years old, said by the Greek philosopher Hippocrates. Today, 1/4 what you are eating will feed your body, I don't think your soul, but your body. 3/4 will feed the income of your doctor. If we go ahead in this way, I think we come in big troubles. And I will show you this a little bit in respect to oncology. As the population is increasingly aging, we will get more and more tumor patients, because cancer disease is a disease of the elderly. And in parallel, we do get more comorbidity, because many of these cancer patients are suffering from hypertension, diabetes, rheumatism, inflammatory diseases, autoimmune diseases, and whatever. And this combination is absolutely a deadly one. And therefore, we look at diabetes and cancer. We have been, I think, the first one who published a book on diabetes and cancer. We come up with all the epidemiological evidence and the molecular links. I can't go into details because there are a lot of molecular links between tumor cells and the diabetic physiology and pathophysiology. Now let's go to the epidemiology of cancer and diabetes, just to give you a small hint. Of course, many of the tumor patients are suffering from metabolic syndrome. That's obesity, that's dyslipidemia, high blood pressure, yes, but I cannot go in why, and of course impaired glucose metabolism. This has something to do with pancreas, liver, and colon cancer. There are intriguing data that type 2 diabetes is a predictor for the mortality in women for colon cancer, pancreas, breast, and a predictor in men for liver and bladder cancer. These are really robust data. These are extremely provocating data. You know that insulin is a mitogenic hormone. I mean, a mitogenic hormone is a hormone which stimulates cell proliferation and pushes the cells into the cell cycle. So if a cancer patient is a diabetic patient and he uses insulin, he has a good chance that the tumor is progressively intended to grow up and to kill the patient very, very early. So you see, this is extremely difficult to see, that we have to avoid that a tumor patient becomes a diabetic patient. But what we cannot do to give them more and more pills to an otherwise already very, very laborious therapy in oncology. There's one exemption. Metformin is an excellent substance, and metformin seems to have a protective effect in tumor patients too. But nevertheless, as I said yesterday in the afternoon, the group from Professor Grawinkel and Dr. Harpicht, and of course the group of Dr. Huang, they have been so excellent at the point of art what we can do with nutrition in health and disease, that we should go further in this way, what they have suggested and what they have summarized so elegantly. Now, what is in diabetes? So we have always to combine it. So I sweep together with diabetes and cancer. In the current strategy in diabetes is non-pharmacological management, diet and physical activity. But how is diet control? How is physical activity control? The other thing is, of course, that's the billion dollar market is the drugs. But there are no new drugs. They are coming up, new drugs. And I show you that these new drugs coming up, that they are very dangerous, at least for tumor patients. So we decided to embark more and more on diet because one third of all incidences in tumors comes from an aberrant use of diet and nutrition behavior. 1/3, that's enormous. If we can prevent that, we would prevent about 1/3 of the tumor, colon cancer, pancreatic cancer, breast cancer. Now, what we do? There's the hidden story of cancer and diabetes. We have published a lot on the Nature, and so what is the cellular and molecular science behind this discovery? And we have to look at that, what has been nicely done by Dr. Huang. Diabetes is not only a disease of the pancreas, it is a disease of the brain, it is a disease of the liver, the muscle, and the adipocytes as a tissue, as a hormone tissue, are also involved. Can we address in a dietary way this muscle and adipocytes in order to regulate the uptake and to regulate the homeostasis of glucoses? Yes, we can do it. When I ask, there are good publications in British Journal of Nutrition where bitter melon improves glucose and insulin sensitivity in skeletal muscle. And of course, they reduces lipogenesis in adipose tissue and inhibits adipocyte hypertrophy. So the literature is good. The literature is excellent. But now we come to the story of GLP-1 and GLP-2. We have to mention both because both hormones are nearly the same. In the ileum, there are cells called L cells. These L cells have to be activated by a cue that they release GLP-1 or GLP-2. So I come back to the Americans, which are crazy. They believe in the story of fatty acids, heart attack, stroke, and so on. There's a background, but the story is not as a whole. So they take out all the fatty acids. That means they do not have adequate cues to activate these cells that they produce GLP-1 and GLP-2. And they take out all the bitter nutritions, all the bitter taste nutritions, because we don't like them, but we have to have them. That's what nicely has been shown by Huang on the receptors. We are working a lot on the taste receptors, because taste receptors are on tumor cells as they are glucose transporter. And that's very, very important to know. Now, GLP-1 and GLP-2 is released if there is the right cue in the nutrition. And if there is no right cue, you have no regular activity of the pancreas and insulin via GLP-1 and GLP-2. GLP-1 has a receptor in the brain. That means it triggers satiety and anxiety. That's why we know that diabetic patients are prone psychologically for anxiety, because they are not able to produce GLP-1, so they cannot target the receptor in the brain, so they have no satiety and they have an increased anxiety. There is also a receptor in the lung, but we do not know much about that at the moment. But that's very important. There's a receptor for GLP-1 in the stomach which delays gastric emptying. That means together with satiety and gastric emptying, it prevents you from overeating, to eat too much. And of course, there is the activity on the pancreas. That means the insulin secretion, the beta cell proliferation, induction of islet neogenesis, and the prevention of beta cell apoptosis, which is a very important point. Again, I salute your paper, but this was excellent. I come back to that what Dr. Wang has done. Now, we thought we have to get a diet which we can offer the patient that he will not become a diabetic patient. That's very important. But we cannot add any pill. We have to do something on the nutrition side. At first, we did an animal study because we wanted to have the proof of principle that bitter melon. I have no time to go into the details, but we can ask it privately. So, because we wanted to see the proof of principle. At first, we have to get a proof of principle, and the proof of principle was in these diabetic mice, where the bitter melon was called by us as glucokine. And as you see here, these mice were treated with rosaglucosine, and of course they immediately decreased the blood sugar. This is the control, where the mice have been fed only with water. And this is the different concentration of the bitter melon, and you see we have an increase or stability. That means we are dealing with a nutritional and not with a drug. So we need time before the adequate activity of the pancreas is activated, for example, by GLP-1. It's interesting, it's normally what you ever know is that the mice do gain weight if they have rosaglucosine. That's the problem with the patients too. And whereas if the mice are on the bitter melon, they keep the weight. That's okay. We also did oral glucose test, and you see the oral glucose test has shown that the control and the mice do respond in an oral glucose test to bitter melon powder. So this is a proof of principle. We don't want to treat mice. Mice are only models, nothing else. We want to treat human beings. So, but this is the proof of principle that we were able to go to the ethics commission and to file a document for a clinical trial. Now, clinical trial in nutrition is difficult. It's very difficult. There are so many pitfalls, psychologicals, and any other biochemical ones that it's not easy to control. This study, what we have done, I only speak for Europe, is, I think, single because it cannot be repeated. You will never get from an ethics committee the approval to do a study in diabetic patients or in any other patient who are on a basic medical support. You never get it. So what you are doing then? You cannot stop the medication. So if now you have the risk, if you think the patients are not well medicated with, let's say, metformin or whatever, then you might think you can work out a small difference between the bitter melon or the nutrition and the control. That means you have to do a placebo-controlled, prospective, randomized study. And that's not easy to do because we have a lot of psychological impacts on that, because if patients are going into a nutrition study, that's not a study of drugs, it's a nutrition study. So the patient's behavior is totally different from that if they are in a study for a new drug approval. But we did such a study together with Professor Hahn, a very esteemed colleague of Professor Garvin in Hanover. And we decided, okay, let's do the study. We take the risk that nothing will come out. We did a lot of parameters. I don't want to go into details because of the time. But all in all, we had 97 patients. And you see they have been all on an oral medication. They've been all on an oral medication. We have had a placebo. This is the charantia group substituted with chromium and zinc. And this is the verum group, just charantia. They got it for 6 months. Every day, before every meal, 500 or 1 gram of bitter melon. Okay? Now we thought what might come out. This was the outcome in a term. Let's say that. This is the bitter melon group. And you see, we were able within 6 weeks, because the primary parameter was the hemoglobin, the glycated hemoglobin, and not the fasting glucose. Because we have learned fasting glucose is not a good bioparameter for that measurements. For many reasons, we can discuss it later. But we were able to lower the glycated hemoglobin from about 6.3 to about 6.2, or 6.4 to 6.2. That means 0.2. Does this mean anything? I would say at first, no. But then I come back to many of the publications from our books, and I can just show us the following. Sitagliptin, now we have to switch. Sitagliptin is those medication which inhibits the activity to degrade the GLP-1. That means it inhibits an enzyme mentioned yesterday called DPP4, dipeptide peptidase 4. Sitagliptin inhibits DPP4, and therefore GLP-1 is active for a long time. And you see, this is a study with sitagliptin, 100 milligram per day, including metformin, and this is the same. And this is a graph showing it depending on the start off value of the glycated hemoglobin. That means if the start off value in such studies is smaller than 7, then they have with sitagliptin, which are medication, only the same effect, 0.2, as we can show in the same way with the bitter melon. So from this, I would say, yes, this is an effect if we can compare with sitagliptin. Do you buy that? That's okay. If not, then we have to discuss it. That's very important. From which value in a cohort you start with the glycated hemoglobin, how you can decrease it. And that has to be really taken into account when you are doing nutritional studies. You see, the smaller or the less active, the less higher the value is for the glycated hemoglobin, the smaller is the difference which can be achieved with any medication or with nutrition. That's a very important message from all these papers. These are very important papers from a German diabetologist. So, yesterday it was discussed the same, and bitter melon has some activity like for PPR, alpha and gamma, and so that's well established in the literature. That's fine. We can embark on that. And we know that in tumor cells, we have a lot of glucose transporter systems. The glucose transporter systems are uploaded the more the tumor becomes malignant. That means the more the tumor is dependent from external glucose. That's the old Warburg effect. And again, this is the very important slide. We have been able to show that we can equally compare the activity achieving with bitter melon with approved medication on the inhibitors of the DPP4 enzyme. And this was the starting point of the crisis of the financial crisis in 2008 and 2009. Why? We have published a paper showing if you inhibit this enzyme, that means if you inhibit DPP4, then you have a lot of other side effects and adverse effects. But the pharma industry was very clever. They did the studies with sitagliptin or the other ones. The studies were only done for 6 months. Within 6 months, the immune system can cope with the inhibition of this enzyme. But this enzyme has multiple targets, multiple substrates. So you get a lot of diseases if you take it longer. And the point was, we have shown that if you take these inhibitor, sitagliptin for example, longer, and we have shown this in cell cultures and in mice, then you are prone to get colon cancer. And now the point comes. I'm sorry, but I'm happy. What I show you now, if this would have been happened to my worst case, I wouldn't be here, because I wouldn't be in jail and prison and you cannot afford the money for which I was accused. Look, everybody of you will agree with me that Forbes is the best economic magazine you have ever seen in the world because it's published. In the United States, there are so-called diabetic investors. They are collecting a lot of money from the rich people in the United States. They say you get an 8% interest rate, and then they put the money in a fund, and they get their 12%, and in between, the eyes of the bankers consuming in the dollar signs because they think now we have the millions and billions, and that's what they have calculated. You see, this was in 2007 with Novartis and Merck. They had an inhibitor of DPP4 just for approval by the FDA, and they just calculated, and the name was at that time Januvia, and they calculated by Lehman Brothers about the income and the revenue will be about 1.7 billion in 2008. That's an enormous amount. That's a blockbuster of a drug. Okay, so far so good. Now read that. The diabetic investor would recommend reading the study by what we have done. It was one of my postdoc PhD students. And we have published this, that DPP4 inhibitors extend GLP-1 mediated tumor promoting effects on intestinal cancer cells. This has been published in Forbes. What did the people who invested the money? Because you know what you are doing if in the United States, when it comes back that anybody says, oh, I have taken Januvia, now I have intestinal cancer, what is my insurance? You, whatever it is. All the people went to the bank, to Lehman Brothers, and they have to resolve the form because they wanted to have back the money. So millions and millions have to be paid back in cash. This was the beginning of Lehman Brothers, together with the real estate crisis, that they are running out of cash, and then they were bankrupt. This was the start of the financial crisis because of a paper which we have published here showing that such inhibitors, that's why I have a little bit of criticism of your last slide, that these inhibitors might become to be prone as cancerogenic substances. And this is the point. We started with the bitter melon. We have shown that bitter melon has the same effect in clinical studies as such inhibitors on the market, which are blockbusters, but we are as good as there. And then we come down and have said, oh, hi, wait a moment, don't do that. And all the people invested the money come back to the Lehman Brothers, and they wanted to have back the money form, and this was the beginning of the financial crisis. So you see, good science and honorable science, serious science, for the patients, for the sake of the patients, because everybody of us can be a patient tomorrow, and we will be a patient anymore. So we have to do the things properly, and that's why I'm very happy that I am here to discuss with you the nutrition story, because nobody likes to tackle this. Because nutrition, prevention, that doesn't bring money. That brings benefit for human beings, that doesn't bring money so much. Because you cannot feed the pharmaceutical pipeline if you have no money. But new drugs are costing, at least in oncology, and new drugs in oncology they are really worthwhile to invent new ones, because the old ones are good enough and they have to get more and more for the people. It's the same for diabetic. You have to take all this stuff lifelong. So why should I change something? But we have to force that nutrition, and you are on a good way with the bitter melon. You are on a good way if you're working out a strategy, not too much to offend the pharmacological industry, but to come up with new ideas like Dr. Huang or the excellent group of Professor Gourd. That was my message. Thank you very much.
Thank you very much. So now is engaging is open for discussion. And I think Professor Wang may have the privilege to ask first question, especially about DPP-4 and GLP-1. Want to say something?
Well, actually, I noticed the four groups in your clinical trial. Two of them are with Momordica, and one is effective. The other with chromium, right?
Chromium and zinc, yes.
Chromium, right.
Because there is the rumor that chromium and zinc might improve the diabetic population. I don't believe on that, but this is a European Commission crazy thing. I don't believe on that. And it's interesting that chromium and zinc, which are metals, they increase the glycated hemoglobin, because it might be that chromium and zinc is binding to very important substances within the powder. And this is the psychological problem. You see here, this is the control group. And in nutrition studies, the behavior of people is totally different from that and in a group study of drugs, because they wanted to be friendly to the doctor. And so in nutrition, they avoid, at the time they are enrolled in the study, to eat more cake and so on. They are very compliant with the education and the eating and so on. because they say after that, when the study is finished, I can do something else. So this is really total another behavior in these nutrition studies. Because nutrition studies do not have so much adverse effects as drug studies. So they behave totally different. And that's why the behavior is better. So of course, they are also in a better way to decrease the glycated hemoglobin, but not of anything else, but to be compliant.
Yes, any other questions from the audience? Yes, please.
This may be just a comment and a little bit of the answer of the last presentation question. The one reason why we do not test bitter gourd in healthy subjects with normal blood glucose levels is that the impact might be less. What you showed, the higher the starting and baseline blood glucose level is, the higher will the impact be of your intervention. So if we do bitter gourd studies in healthy subjects, we might not get any significant results. So that is one reason why we did not use healthy participants. We wanted to look at pre-diabetics or diabetics, which do not have adequate blood glucose control even under medication, because the impact might be higher.
That's correct. But this is a discussion in Europe on the European Commission. The European Commission wants to see these studies on the normal people, because they know very well that you can't do this study. And you never get an approval to do this in diabetic patients. And you have to take the risk, because they are in medication, and you have to think that they are best medicated, so you don't see a difference.